So next is chronic pancreatitis. It's V13. A 50-year-old lady who is known to heavy drinker, present with recurrent bouts of abdominal pain that are now persistent. What are your thoughts? Chronic pancreatitis is a possible diagnosis. This is a poorly understood, but it's considered that progressive and irreversible end-stage fibrosis due to the recurrent pancreatitis. The cause of pancreatitis are idiopathic 20%, gallstones, ethanol, trauma, steroids, and immunosuppressants and other medicines. What features do you expect to see on the imaging? Pancreatic calcifications, pancreatic ductal stones, biliary and pancreatic duct strictures. And MRCP is good at ductal dilatation, localization of ductal strictures, and CT, parenchymal calcification better. And there may be features of complication of chronic pancreatitis like pseudocyst, pseudoaneurysms, corresponding vein thrombosis, ascites, splenomegaly, varices. How do patients with chronic pancreatitis usually present? So they can present other pain, and this happen due to pancreatic ductal hypertension and phenotypic modification and upregulation of the visceral sensory neurons, pancreatic ischemia, toxic metabolites, and individual genetic polymorphisms. Pain can also be secondary to complications like abscess, cyst, duodenal bile duct stenosis, exocrine deficiency, malabsorption, malnutrition, steatorrhea, diarrhea, weight loss, and endocrine insufficiency, diabetes mellitus. What are the principles in the management of this patient? Depending on symptoms and underlying cause, pain relief step-up approach according to the WHO step-ladder pattern, judicious use of adjuncts to avoid opioid addiction and dependence, psychological support, transcutaneous nerve stimulation, slick nerve block, and acupuncture, and alcohol abstinence, which is not going to reverse the pathological process, but it prevents recurrent insults, which hasten the progression of chronic pancreatitis. Exocrine, endocrine replacement, pancreatic enzymes, dietary advice, oral hypoglycemic agents, and insulin. She does not improve with the conservative treatment and has persistent pain. Imaging shows a dilated pancreatic duct, parenchymal calcification, and intraductal stone. There is no pancreatic head mass. So I would recommend surgery. So there is a step-up approach after conservative, then endoscopic techniques, therapy, and then surgery. However, the pain relief for symptoms are equal regarding outcome-wise in endoscopic therapy and surgery, but in the longer run, surgery is preferable. What are the surgical options available? So it's the resectional as well as drainage procedure, and the most common drainage procedure is the lateral pancreatic jejunostomy. And the resectional procedure are to resect the head of pancreas, which is the pacemaker of the inflammatory process and the pain. And Whipple procedure versus duodenum preserving pancreatic head resection like Beger, Frey, and Byrne. And the choice of procedure must be tailored according to the surgeon's ability with the procedure and patient decision. Thank you.